Patients with OSA who use CPAP at home can use CPAP in hospital, providing that nothing has changed in their circumstances. The ward nurses are not trained in the CPAP machines used in the community. There are too many variations, making it an impossibility. Therefore, the machines are exempt from the medical devices policy training and competency document, i.e. the patient knows what they're doing, so it's safe to let them carry on using the machine as they would. If there's any change in the patient's condition, such as they can no longer put on their CPAP mask and, crucially, remove it if there's a problem, they cannot be safely managed on the ward. For example, a patient who has an ingrowing toenail removed under a ring block would be absolutely fine. A patient who has had bilateral elbow orifice would not. There's clearly a spectrum between these two extreme examples. Excluding post-sedation and anaesthesia, no harm will come to an OSA patient from missing a night of CPAP. Patients with pure OSA do not require supplementary oxygen day to day. If there's a change in the patient's condition, such as they need changes making to their CPAP circuit, e.g. the addition of oxygen, they cannot be safely managed on the ward. The patient will be unfamiliar with the setup, and as above, the staff have no training and they too will be unfamiliar with the setup. As an aside, domiciliary machines are not idiot-proof because manufacturers don't expect access to different bits and pieces. It is frighteningly easy to feed a patient their own CO2. The purpose of CCOT is to identify the sick patient, to instigate early treatment and to guide escalation to higher levels of care. They do not have the resources to nurse patients in critical care beds outside the recognised units. We have developed an E12 step-down checklist to ensure the safety of patients stepping down from E12, but it cannot predict the future course of the patient's illness, clearly. In summary, ask, is the patient, as well as they are at home, and using exactly the same setup that they use every night of their lives? If yes, carry on. If no, transfer to level 2. Domiciliary NIV. NIV for sleep disorders, obesity, hyperventilation and others can be considered as above. NIV for any other reasons, e.g. neuromuscular disease, is usually used in a heavily supported environment involving spare machines, carers, night nurses, etc. This cannot be replicated on a general ward, and the patient will need to be on RQ if they have simple additional needs, or a level 2 critical care bed if they have significant extra needs, including surgical ones. Patients who use domiciliary NIV cannot safely miss a night of assisted ventilation. Elective admission of these patients is to be orchestrated and should not result in unplanned level 2 admissions. In summary, ask, does the patient have the same care needs they have every night of their lives at home but are missing their carers? If yes, carry on in RQ. If no, transfer to level 2. The new surgical level 1 unit is being established to help with patients who need ward plus care. The management of CPAP and NIV is a level 2 competency, and therefore there is no additional care available in this domain beyond the typical ward environment. Therefore, manage as above.